Today we were going to hear from a couple of people.
And we're recording.
There we go. We have a couple of people that we're going to report out. And today we have to come through kind of like with some of the ideas. And I think we might have to hold one more meeting just to flesh those out to see what types of things we agree that should be proposed. So we'll start right away about first with our homework assignments. I know Mary Pat was going to bring some information. Do you have that today, Mary Pat?
I do have that information. So if you wouldn't mind if I could go first.
Absolutely.
Okay. I'm going to share it. I just typed something up pretty quickly. Okay. So basically we have four major challenges that we're facing right now with DD services. Our staffing, of course, is our number one issue. We had a recent board meeting and I put data together, and it was very disheartening that in the first quarter of this year, we only hired 3% of all those that applied to the Kennedy Center. And 65% of people that applied don't even respond to the first outreach. So finding the staff that we need has been difficult. We have 45 individuals that are still on our waiting list that we can't bring back because we don't have the proper staffing. We also have 2 years worth of individuals, young children that or young adults that have aged out of high school that we haven't even started to think about providing services to. So that's our number one challenge. The second challenge is the reimbursement rate that was provided by DDS. If someone does not require one-to-one services, the reimbursement rate is adequate. But if someone needs, say someone with Alzheimer's or severe dementia and needs a one-to-one staff, we lose $6 an hour for every hour of service. So that's a challenge. Transportation cost has been a challenge. We receive on average $4.62 per trip. And before COVID, we lost $350,000 in transportation. So it's unsustainable for us to continue to provide transportation. And I know that transportation is key to good day services. And the other challenge that we're now facing is the CMS final settings rule. I don't know how much people know about that, but CMS, being the Medicaid provider, is instituting this final settings rule where we need to provide what they consider to be true community-based services that are not considered congregate. These will be required. This will require more staffing, where individuals would get more one-to-one attention. And not everybody wants that. And DDS, and the providers are, committed to being person-centered in the programming, but the final settings rule is pushing everybody out into the community kind of on their own. So those are the four challenges we're presently facing.
So can I ask, how much one-on-one time? Does it require a certain amount?
It depends on the person. Okay, so like I said, if someone has behaviors or has intense needs based on their Alzheimer's or their dementia, they would require a one-to-one the whole time that they're there. So typically the DDS day programs are 6-hour days. So that would be, 6 hours a day plus transportation time.
Okay. Any other questions?
Dawn, maybe, was anybody on the Medicaid waiver for DDS yesterday, that Human Services and Appropriations one? It was about expanding the wraparound services if somebody lost their, staffing, especially like going into a hospital. That was one of the things that could be reimbursed. But I'm just wondering if that's tied with this final settings rule that you're talking about, Mary Pat, with, basically these programs picking up the difference.
Possibly. I don't know what, specifically what that conversation was. But that's a possibility. But the way I understand the final settings rules doesn't really have anything to do with hospitals as much as it in general congregate settings. So CMS is considering congregate settings to be any like group day services where everybody kind of stays in one place for the better part of the day, where they want them to be out in the community at all times. So,
right. They had said that they didn't have anybody that was getting reimbursed for congregate settings, that they're all considered pre-vocational now out in the community. That's what they said.
That's interesting because not everybody is considered pre-vocational. People are considered day support options, and they're not any thought about employment at that point. They do some volunteer work. They do a lot of community-based recreation. But,
well, one of the comments from, again, this was from DDS, was that, again, it aligns with what you're saying, is that they're not reimbursing you anymore, right? For
right.
the congregate sheltered workshop type of day programs.
Sheltered workshops, correct, are no longer in existence.
Right.
But so what happened was many of those people that were in sheltered workshops that were not quote unquote competitively employable went into the day service options.
Got it.
Okay.
And that's what you're talking about, is not reimbursed
right.
at the rate you need it to be, or you've lost some of that, right?
Yeah. Yep.
Okay.
Yep.
I think that gives us a clear picture then of what we are looking to help invest in as a, because CMS is not,
right.
Not getting federal funding for that.
Right. So that's the challenge there, is that there are people that have this need, which is much like those that are seniors that have a need for recreational day supports. But if DDS isn't going to get the reimbursement from Medicaid, the 50% match, they're not going to pay for that. So what are we going to do with that population? They're going to have a one-to-one staff, and they're going to be out in the community driving around. There won't be as much structure as there could be now. And again, it needs to be person-centered. It's not person-centered. It won't be person-centered if they're pushing people out. Many people like coming to day program because they're with their friends. So that's the challenge going forward.
Dawn, did you mean for today? You're muted.
Thanks, Representative. I was just, it seems like there are a lot of questions about DDS, which is a separate funder, and DDS isn't at the meeting. So
right.
General questions about the settings rule, Jen can certainly jump in. That's under her responsibility. To maybe some clarification on settings rule would be helpful for the committee.
Okay. Jen.
Yes, I did. And I think, Dawn, I would agree inviting DDS because, certainly they could speak to, because I do have some questions about, Mary's comments related to the settings rule and day centers. certainly, requirement for one-to-one. The settings rule really has to do with that. And it was created because a lot of institutions, quote unquote, were claiming to be community-based, but really, still were like an institution, and we're not really allowing members to be, part and engaging in their community. And that's really the basis for the settings rule. Some of it does tie to, if you're an adult day center that's part of a campus, looking at that separately. And I'm not sure, Mary, at this point, if anybody has, come out to your location to do a survey. Certainly on the DSS side, we have done that to, work with providers, just to ensure that they're in compliance with the settings rule, because obviously, we don't want to, take this, great community support away from the members that we serve, but we want to work together as partners, to ensure that the member has, access to being part of their greater community. So I think I definitely would agree, partnering with DDS and having them join, just to, speak to certainly some of the reimbursement rates on their side, but also just implementation of the settings rule.
Great. We'll invite someone. Does anyone have anyone specifically in mind?
Probably Krista Oshachevsky. She's the waiver, manages the waivers.
Okay, great. Okay, great. Any other further comments, or probably best to hold till we have someone here that can help us answer those questions? And thank you both.
I have to run.
Okay,
Thank you. I gotta run.
good luck with everything, Mary Pat.
Thank you.
Okay, we also had do you have information on transportation to and from?
I don't have the stats besides what I sent you, the draft from our little subcommittee meeting, but Chrissy, do you want to talk about, or Cheryl, to sort of summarize our little subcommittee meeting that we had last week?
Sure. So we talked with, and Cheryl and I were actually already speaking this morning, so she can jump in as well, about the transportation to and from adult day centers. So we did, we have previously provided some information to DSS as part of our meetings with them in regards to the cost of our transportation. And we did it based on different regions in the state. So we did it based on an urban or more like city area where you can, people are closer together versus a more outlying town where people are spread apart farther. Cheryl, you have those numbers?
Yes, we figured out that an average trip might cost between about $17, $16.90 to $17, with about 90 to 100% using transportation, since most do, but there are some cases where people don't. Just a little more clarification about an urban versus a city center. So I would consider my program urban because we go to several towns, or maybe with the same bus, making that trip obviously much more costly than in a city like Bridgeport, where maybe you could go to one building and pick up 5 people or to 10 people, then go back to the center and maybe hit another building.
Thanks. So we took that information and then used it with the estimates we had from the last meeting about the numbers of Medicaid participants, because Representative, you'd also asked for what is the, again, these are very rough estimates. Of course, we'd have to get, exact figures, but rough estimate of how many trips per day adult day centers are making. And we had come up with about 588 total members with an average of 3 times per week. And that's just an average based on the fact that some clients don't solo come 5 days a week, some come 2 days a week. And also, like what Cheryl said, some people don't actually utilize the transportation. They either have family members drop them off, or some live in the same building as their program. There's some housing buildings that are located proximity to programs. So the total cost of what it is we were actually doing the rough numbers, and I caught a typo in my calculation after I hung up with Cheryl. So it's actually a little less than what we had originally thought. But it's about, for the average year with the operating year of 250 days, about $2.5 million. And that would be for all the centers that we have information from in the state.
So can I ask you to clarify, Christy, when you said an average of trips, 588, is that per person or per trip? Like are you aggregating the
Sorry,
trip or
no.
per person?
Sorry, that is 588 members, Medicaid recipients,
Okay,
with an average attendance of 3 days per week,
okay,
2 trips per day.
right. And so the
cost, yeah,
the average trip cost of $17, is that per person or per trip? You
that is
understand?
per trip.
Per trip. So, so like you say, they might be picking up several people, right? Per
That
trip?
is, no, that's an individual person.
Oh,
Sorry.
okay, so
It's
it is
not a
per
van
person.
trip. It's not a van trip. We consider a trip picking up one person.
One person,
So,
perfect.
yeah,
Okay,
yeah,
I
and
just
in
wanted to
some
clarify.
places, like where I'm located in Bridgeport, we go to a senior housing building, we may pick up 5 people. Where Cheryl's located in the area like Windsor, she has to go from one house to another house to another house. Same thing with a program we got information from in Norwalk. That was actually the one we had used. And then there's another factor as well, which we didn't even include in this because we understand we can't calculate it directly, is that some people use contracted transportation. So they're paying even more than $17 to an outside provider to show up. These numbers are just based on centers that use their own vans. And the way we calculated it was through the same tool that other states use to get an actual transportation rate. We based it on, for example, just because I have easy access to the tools in Massachusetts where we operate, the Medicaid there actually has a form you fill out to get your transportation rate when you open your program. And it has like a set of calculations, your vehicle, your maintenance, your drivers, your insurance, your depreciation, everything like that. So we actually use that tool to calculate these rates. So it's not just like an estimate, it's based off of a tool that's currently used. Some programs, it's crazy. Some programs between, off the top of my head, is it New Jersey and in Massachusetts as well, they get like over $20 per trip. And some of them, their expenses is even higher, but it's insane right now because of the increase in cost. A lot of that went up after COVID. These numbers are just based on our regular cost. The only thing that has increased from previous times that we actually reflect here is the cost of gas.
So we're estimating an average per user trip of $17 cost.
Yeah.
And we're looking at 580 members, Medicaid members across the state. Although, like we talked about last time, we're really want to anticipate, I think we can anticipate an increase in user if we get the systems working. You know what I mean?
Like, you're absolutely right, because in addition to that, these numbers were calculated back when we were having these conversations with DSS at the end of last year. And that was during a time where you can see the utilization was actually down, actually on Miss Dawn's chart from last time. The utilization was down. That was because there was still almost half the centers were still closed. So this is now that it's 2022 and centers have reopened, we're at 35. I think Cheryl and I just calculated 35 operating centers with only 3 not operating. Whereas when we did these numbers back in the previous fiscal year or whatever it was like half the centers were still closed. They couldn't even operate. So, yeah.
So we would need to scale up our estimates probably in terms of utilization. Go ahead, Dawn. Do you have any info?
Yeah, just 2 quick comments. I think that our trend analysis on a lot of the congregate settings and choice, we do think that COVID has impacted member choice. And that there definitely is some decrease in demand. It's likely going to go up a little bit, Chrissy, but it's unclear at this point. It looks like there's some long-term impacts related to COVID-19 and where people choose to receive their supports. That's just our estimates. I do think that there are options that Chrissy knows we've been presenting that actually expand options for adult day that might be give a little bit more maybe a little bit more aligned with where consumer demand is right now, because of course that's DSS's job, is to make sure that we build supply consistent with what people and what members are saying that they want. And I think there is an opportunity for adult day to do things a little bit differently than they do right now and expand sort of their book of business. The last thing I just wanted to say quickly is the department, and Jen may be able to comment more on this because I have not analyzed not into the weeds of the methodology, but the department has, and I think that Representative Hughes and Garbe, I think you're aware that the department has engaged in a rate study across all home and community-based services. And it might be where, I don't know what's going to happen as a result, but I do know that the department has paid an actuarial firm to really look into how did we do rate setting in the past, including transportation for adult day? Where are we maybe out of line, and make recommendations to the department on appropriate increases based on a sound methodology. So it might be a little bit there that's worth unpacking at some point in the future. Jen, I don't know if you have any details on the adult day and if there's a next step. I missed the meeting last week on that one.
I don't have a recent update, but I certainly can report back at our next meeting and give you an update on that.
Great.
Any questions from anyone?
One quick question. Since we were looking at that demand for and utilization, we had asked last time, but I think Ms. Dawn had to, you might have had to get off the call. It was like running late. We were wondering if there was updated or any utilization that reflects anything from the last year. Because those, like I said, those numbers, what you had was while the centers were still closed. Can we get updated numbers to see?
Absolutely.
If that's I don't know how often it refreshes, because the young lady who, by the way, presented so nicely to the group.
Thank you.
She was a little nervous, but she was very informative and very knowledgeable, who presented to the group. She had mentioned those numbers were from the previous fiscal year. So we were hoping at some point we could get updated numbers and that we would see, some of that growth coming back.
Yeah, and you likely will. We're happy to refresh that, Chrissy. The only additional comment I want to make on that is we can't go to today because there's a lag in claims. So
Right.
you'd see an artificial decrease if we pulled the last 3 months just because the claims aren't through the system yet. Typically, we use a 6-month lag. I could do 3 months, but just with the caution that
Sure.
it might look a little bit lower just because some claims aren't in, but happy to refresh that for you.
No, that would be great, because the one that we saw actually only went up to the middle of 2021. So even if we could get to some point in 2022, it would still show something that we could use maybe to just get more accurate for our figures. That would be awesome.
Sounds great.
Any more questions on that? So we had calculated that today was possibly our last meeting with one more on the books in case we needed it. And if everyone's willing, I think we need to have that last, meeting. So where are the areas that we think we can help adult day centers? We've talked about transportation. That seems to be like a big issue, not only with adult day centers, but in other areas. We've talked about lowering the age, right? For early onset Alzheimer's and other, what else?
My sense, Jane, is we're going to need to come up with a menu of proposals to the legislature of how better to invest in adult day centers. And think about it. We made all public transportation fare free, but we didn't replace that in our adult day transportation. And going forward, the governor may, help recommend that we continue that and replace the special transportation fund with some other stream of revenue. But we want a piece of that action is what I'm feeling like. We want adult days to be in that public transportation investment. Just because people are seniors or disabled doesn't mean they shouldn't be able to get that same level of funding support. But also we were looking at, we talked about the 3.5 million that we built into this budget. That still hasn't been disseminated yet, right? So we're going to have some real recommendations, not only about how to get that money out the door to these struggling programs, but how to increase that, and be proud of that, be championing that this is a really important service that we're providing to our communities across the state, and to, maybe make that much more amplified. And then the staffing issue that was raised earlier in the meeting, it's obviously difficult to staff. How are we going to address that? So those three tranches I sort of see is hardcore proposals, and they're not going to be just one thing. I see it as a menu.
Well, that's what I was trying to do, is pull it all together. So when we're talking about staffing, we didn't talk about any possible solutions.
We haven't really.
And I hear a lot, and I know in the business community, many businesses have taken steps for certifying employees in manufacturing, having education programs, and those that have done certain things are now pretty fully staffed. In adult day centers, what can we do to help staff? Mag?
I just wanted to sort of fill in. There's a lot of work being done in the Office of Workforce Strategy. In some of those, like the pipelines they use for manufacturing, they've now moved it to healthcare.
Right.
So we've been working with them, and they've included the post-acute care, which is kind of their term for, the long-term services and supports training in that. And also nursing, because of course each adult day medical model needs a nurse, and nurses are, they're a hard commodity to come by. But CNAs and other people, and trying to attract people into the field of long-term services and supports. So there are some things that are moving in that direction. And I think one of the things we of course like to see is some kind of public awareness that there are these options open to people as people are looking for careers, that, that post-acute care is not just a nursing home. There's adult day, there's home health, there's, homemaker companion, there's all sorts of opportunities for people in that sector. So that's one area we'd like to see potentially grow a little bit or move forward, is just some of a public awareness. But there is work, and I just wanted to let people know we're very pleased with the fact that the Office of Workforce Strategy and others are really looking in this area. The other thing, I just wanted to say one thing about the transportation, and I would be interested in knowing the adult day center's opinion. One of the issues is that, the cost of providing adult day services is causing some places to close and being able to attract people. And if you're in Hartford and you've got sort of that concentrated population, and it's easier to run your transportation, it's a different business model than in our rural areas, as I think Cheryl was trying to say. If you're up in Litchfield County, for instance, there used to be several in Litchfield County that have closed.
Mm-hmm.
But if we were able to provide that transportation cost separately and pull it out of the rate, it might encourage areas of the state that currently aren't served by an adult day to be able to provide that option. And particularly if people are, in areas where they are quite isolated because they aren't in a neighborhood or in a building or whatever. So it's just a thought, sort of adding on to that idea of enhancing the transportation reimbursement, since right now it's just required in the per diem rate.
That's a
And
good idea,
Did
actually.
you have any comments about exploring the PACE model of reimbursement?
The PACE model, I think the PACE model would be terrific for the state of Connecticut. I mean, I think it would be a great option for people. It's not going to be it's for a particular sector of the population in particular areas. But I think there are a lot of nonprofit providers out there that would love to provide the PACE option for their community as part of their continuum. I think that so many other states have done it that we would have the expertise to know how to do it well and to do it to make sure it's financially sound and that there's the right, I know there's a lot of concern about the oversight because of the payment model, but but PACE is very, in other states, it's seen as just sort of the epitome of the vision we have, right? All the services you need to keep you at home and keep you in the community and make sure, it's got an 11 disciplined, care team that's looking over each individual. It's small, 300 people. I mean, that's large, but small. So everyone is getting individual attention. It seems to be something that would really benefit a lot of different communities in the state. And I think, and willing to have the oversight that some people are very, some advocates are very concerned about. And I understand their concern. I'm not, saying their concerns aren't warranted when we look at certain types of reimbursement models, and it's a capitated model. That's the model that people are concerned with. But I think with PACE, there are some safeguards in there and some oversight. And I just think it's something that for certain communities might be a really valuable model to put into place.
How do we think, like transportation is different with rural and urban? How would the PACE model affect our smaller, more rural day centers as compared to the large Bridgeport day centers?
Well, PACE would be concentrated in one community. And I know, Dawn, you can comment because you may know more about this than I do. I know from someone who's sort of looked into it, but you're the expert. But so it would be, say, in the center of Bridgeport or West Bridgeport or the East Hartford, or you know what I mean? They pick a community and it's centered around a center that provides sort of the medical services and support services. It provides transportation. It has adult day services. Has actually like 11, I think it's 11 disciplines that are in the care team, social workers and dietitians and physicians and nurses, and, to make sure that each individual is receiving, sort of has that person-centered care model. So if you had a PACE model in Bridgeport, it would probably collaborate with an adult day center or two that were already there. It doesn't have to be one provider. It can be one provider sort of runs the PACE program, but can partner with other providers. I don't know if it would work in a rural area, but it could.
But would it free up resources? That's my question. If we modeled the PACE in, say Bridgeport and East Hartford, would it free up resources to extend from the state to extend to those rural areas that have no transportation and no program?
I don't know. I don't know whether because you're thinking that people would come into the PACE program, it would save the state money and those resources could be shifted to the rural area. Is that what you're thinking?
Well, the PACE model has more reimbursement, right? From, the dual reimbursement, right?
Because it's got Medicare, right?
Right. And we're talking about the 588 people that are on Medicaid, right? Members on Medicaid.
Right.
And so we're talking about the cost, for instance, of transportation that is not getting reimbursed. And Mary Pat was talking about the cost of like one-on-one that's not getting reimbursed. My question is, how can we invest in more, more people getting more services, especially in those areas that are hard to serve, like the rural service?
Well, you would have to choose to enter the PACE program. So if some of those 588 people moved into the PACE program, the payment source would change to the PACE reimbursement as opposed to the adult day reimbursement.
right?
But we don't know if any of those 588 would choose the PACE model.
Got it. Okay.
Mhm.
Dawn, Beth thoughts.
Yeah, so, and Mag's also an expert, by the way. Thank you, Bud A. So we do pretty good tag teaming off of each other brainstorming. So I just wanted to make a note that the department is exploring PACE under the ARP 9817 as one of the innovative services. I don't know what the outcome will be of that, but there is a work group that's convened. Mag's on that work group. We haven't started to talk about PACE yet. We're talking about food right now. The first thing that we worked on was live remote kind of community hub. That's actually going to be moving to the legislature probably in the next 3 weeks. So you'll see that. And that's the initiative that we just went to Chrissy's meeting and let the adult day centers know how they might be part of that. We actually wrote in opportunities for them within that specific initiative. The second one that they're going to work on, once again, is food. The third one is PACE. Whether or not it saves money, I don't know. People, as Mag said, and one concern that we have is whether or not there is sufficient demand in certain areas for people to opt into a PACE model. It does require that Medicaid applies under a different authority to operate the program. So it's not a short timeline from decision to try to move forward to actually getting something in place. There's it's a different authority of the Medicaid program that we'd have to apply for. But there are states that experience great outcomes. I think one of the criticisms historically was lack of data, as Mag is saying, because it's a capitated model. I know there's been some recent research on that suggests that there is data there, but we'll put it all together with the innovative design, move it forward to our commissioner, and we'll kind of take it from there. I just wanted you to know that we are exploring it as an option. We're aware of the success in other states. It is community-based, totally community-based. It's an integrated model. Once again, the concern is we have pretty strong DSNP enrollment in the state. And so one concern is, would individuals leave their existing DSNP to enroll in the PACE? And we don't know the answer to that. But so anyway, we'll explore it all. But PACE is known as being an integrated model. So to your point, Representative, it is really not just integrated at a community level of a whole person approach, but it's literally integrated with Medicare. So Medicare, Medicaid partnership, which is something that we don't do very much. We don't have a strong model in the state to do that. So more to come, I guess.
Well, I'm happy to hear that another working group is exploring that. So, maybe we can just sort of say in our report out that, that the conversation came up. Again, we're trying to figure out best ways to invest in serving more of our community members that need adult day service.
Mhm.
Okay. So, but it sounds like that would not be the PACE program would not really support the smaller day centers in the rural areas.
It might. I mean, it depends on who joins it depends on kind of who joins the model, who has the lead on the model, and then they convene the partners, because you do have to have certain key partners in order to have a viable model. It's a little bit of a template, right? And then once that model is there, you have to have sufficient demand. So I'm sure they do some marketing up front to kind of test the waters, if you will, and find out if they think they have sufficient demand. Because if only 50 people enroll, the economies of scale aren't there. They can't operate. So that is one of the challenges of the PACE model, making sure that they have the numbers so that they can actually reach the efficiencies, and then otherwise it falls apart. But yeah, so more to come on that. But a small adult day, I don't think there's any reason. Mag, do you disagree? I mean,
No, I don't. It depends on where the PACE model locates itself
it's
and
community.
what the geographic area they're going to cover is. But they definitely would probably prefer to partner with a smaller day center than to create a new one in an area like that, an established one. That's sort of been the history of it.
It's aligned philosophically as well with the model, because it's community-based. It's not starting something new, it's building from the community up. and coordinating the existing array of services, but coordinating them differently in a way that delivers that service and that continuum within the community differently to the person, so the person's experience is different.
Okay.
So just as a quick addition, we do have some experience with PACE from Massachusetts as well, and the programs have been very successful. There is actually, from what I've heard in the Massachusetts Association and the National Association, is that pending the note that there may be PACE coming to Connecticut, providers from other states are already interested in coming here, which is good in some ways, because of course we want to expand, all types of services in Connecticut, but also could be seen as intimidating to programs that are in existence here, because they come with funding and experience and things that could detract from current programs, which is where I think some of the smaller programs or areas that we're trying to get service to may see some, some sort of conflict there. So I think that's, but that's just the way of business. That's the way of the world. And of course, if it eventually means that more seniors are getting service and more community members are getting service, that's great. But just to the point that Representative Garibay was making about the smaller centers or the rural centers, we would hope that PACE providers would use their judgment in wanting to partner with existing programs. That is a hope, of course, but you just don't know exactly. You can't foretell what's going to happen. But there is great benefits for the programs for the community members. We have a couple of programs that we're affiliated with in Mass, also some in Kentucky that do provide. It works well with bigger programs and more densely populated areas, like what Mag and Dawn were saying, because we have the numbers, you have the people there to make it a viable entity, to have more. The cost savings comes once you reach a higher scale of service. So that makes sense, but it's definitely worth finding out more about, and look forward to seeing how it will come and help the communities here. It'd be great.
And that's what I love about this group, is that everybody's open to all options. I have to say there were 2 people that wanted to be in this group, but they were very anti-PACE, like it's the evil. And I still don't understand that, from what I'm hearing and what I've learned, that it is a possible option. What can you tell me, Dawn, Mag, anyone on this panel, why are some people that are involved in helping our seniors that are so opposed to PACE?
I think Mag alluded to this. It's some people feel that capitated models lack transparency in how the money is being spent, and that there could be a possible negative outcome, and that people wouldn't get as much service, and that we wouldn't know because we wouldn't see the actual underlying data. So it's just a concern. It's a longstanding concern of some folks in our state. Mag, I'll defer to you because you've been there to hear all of the debates as well.
Yeah, and we understand sort of their concern. With a capitated model, you're paid per member per month, right? Or however it is, per day. And you cover all their expenses in that payment. So if you're a for-profit insurance company, say, and I'm not saying anything against insurance companies, but I'm just using this as an example. The concern is that they're going to take a per member per month, and they're not going to pay anything for the claims or pay for services. Whereas PACE is modeled so that everything is judged by outcomes. And the whole concept is it's truly managing the care of someone, similar to our ASOs, right? And you're getting a payment from Medicare and Medicaid, and you reinsure yourself for all, for the big things. Someone needs a heart transplant, that's on you. You're reinsured for that, so you can cover that. But the whole concept is that you're required to have like this large disciplinary team. The group that you're covering is only like 200 to 300 people. So each person individually. You follow each person individually. You ensure, when they go into the hospital, you follow them into the hospital, so that you're informing, similar to, how you always say someone needs an advocate in the hospital if they're older. And they go in there and they go to the emergency room. They follow people into the hospital. They make sure the hospital understands it. You know, they're partnering with the hospital. This is who this person is. We know what their makeup is. Yes, this is, you know, they're here because they broke their arm. Maybe you're going to find these other things. We're monitoring those other things. They don't need to be, you know, admitted because they have A, B, and C. We're taking care of those comorbidities. They're here because, you know, they fell and broke their arm or whatever. And just making sure that they have this team that follows them throughout their lifespan, or as long as they're in the PACE program, doing everything they can to keep them in their home and keep them integrated in the community, right? And respond to all of their needs. So if you look at it as, yes, but they want to make money off these people and they're getting a per payment per month, so they don't want to spend that money, that's not how the PACE program is judged. You know, they are looked at for that. And as I'm saying, because it's been in so many other states, we can put those safeguards in to make sure everybody is receiving all the care they need, that they are responsive to their needs, the outcomes are looked at. And I think we have a very sophisticated Department of Social Services when it comes to that kind of oversight, as you look at the, you know, managed fee for service program that we have. So I think that coming into our DSS and our Husky program, that the PACE program, it's almost an ideal setting for the PACE program to come in, because that's exactly what our department's tuned into: outcomes, service delivery, and I, you know, I saw a presentation just recently on the PACE program that's going on in Massachusetts and Rhode Island. And I asked about the DSNP question, because I know this is a concern of ours. I said, do we even have the, you know, enough people to fill a PACE program? And their response was, in their PACE programs, they take sort of the people that are the most in need. Like the DSNPs are handling it, but the people that sort of rise to the top of needing that extra oversight, those are the people that come into PACE, and they actually coincide with the DSNP programs quite well. And you know, so I think that if we did put it in Connecticut, we would have to respond to the people that are concerned about the capitation, and just put in that transparency and that oversight that is desired, so that make sure that the people that enter the program get the services they need. I guess that's my only response, is that I get it. We don't want anybody to have services restricted from them. We want this to work. We think the outcomes will be better than they're currently receiving in the programs they're in. And so I think we just address those concerns and make sure that we have transparency and oversight put into it, and a real sharp eye into the outcomes of the people that are participating in the programs. And because I think that the outcomes will be great. And I think that we'll see that people that enter these programs will really see the benefits of a truly integrated PACE program. So willing to, you know, and I think the people, for instance, in my organization, my members that want to get into the PACE program, I think they would be extremely receptive to full transparency and oversight. So it's easy for me to say that, because I know that that's sort of the values of my members. But that's,
And it's opt-in, right? It's
opt-in, right?
Right.
And you can
Well,
opt out.
It sounds like Shangri-La of, you know, the program as you're explaining it sounds wonderful. Is it DSS that will oversee that?
Yes, I think so. I think it would be the DSS's, yes, position.
Dawn, do you want to
They would
speak?
have to apply for the PACE program. They would have to put the program together. They would have to put in what the oversight was. And, you know, and how they would oversee the providers. And it was probably an RFP system where, you know, you'd have to put in your bid, your RFP, and explain how you were going to run this program. I think in a couple other states, one of the issues have been, you really have to make sure the provider is financially sophisticated enough to run this program, because it is an insurance program, right? I mean, they are getting a payment, they have to cover their insurance. And I think we can learn from the other states how we would do that, how we would view the providers, review them, make sure that they're competent and capable to be able to run the PACE program. I'm not speaking for DSS, but I just think that we could learn from other states for sure.
Right. Dawn.
So, yeah, and we do all of the time. We learn from other states all the time. PACE isn't new. It's been discussed for years. It's been around for years. It's not new. One thing that is a little bit new in our state, though, that's worth thinking about with respect to the question, is there demand? Is this what people want? Are there people who would choose this? Which of course is our job, right? What can we develop that's good policy for the state and is what we're hearing people would like to have as part of the continuum, and then build that supply. What's interesting more recently than 10 years ago, for example, in our state is the D-SNP enrollment, which is managed care. D-SNP's not fee for service. D-SNPs are actually managed care, more like PACE in some ways. In that respect, it's a managed care model. It's not fee for service. People are choosing it. You know, the enrollment in D-SNPs in our state is exponential over the last 5 years. Where the last time I looked, I haven't seen a recent report. The last report that I saw was the enrollment of about 75,000 of the more medically complex Medicare members. I mean, it's the same cohort. And as Mag said, maybe it's the higher end of that, but that cohort of people is more often,
Growing.
yeah, they've already gone. They've already chose, like they had their choice for Medicare and they're choosing managed care. So, and I think Representative Hughes, you said it's a choice. Right? We're not telling people to go to PACE and we're not advising that they go to D-SNPs, but I feel like it's our job to provide options for the public and then to great quality options and then let them choose. So anyway, that's what we're hearing from the public. So hopefully we'll have that report, but I just wanted to mention D-SNPs are managed care. And the enrollment's up in managed care, which just reflects the population of the people that we serve.
Okay.
This
thanks.
is helpful.
So the five, someone else want to say something? Okay, so what I'm seeing is transportation, that we've talked about the 5 things. Transportation, where's the 3.5 million, and you know what's going to happen with that. Staffing is an issue. PACE and using the integrated model, and education and messaging. There's a new program out there with realtors that they can become certified. So instead of just selling an elderly person's house, they kind of follow them. I don't quite understand it yet, but I have a realtor in town that is doing it because they become invested in their client. They've known the family for years, especially in our smaller towns, and to follow them. But there's lots of groups that need education on what's out there and where to refer people to. So I think education and messaging, with me calling them adult daycare centers in our first meeting, and now I know they're adult day centers, but just that messaging and talking. We're out meeting lots of people now because it's election season, and when they think they're going to be taken care of like babies, they find it very offensive, right? So it is that messaging that this is a different model. Is there anything to add to those 5 points?
We had talked about in the last meeting as well, the age range. There was one of the programs that on the chart, the colored chart from Miss Dawn that she had submitted, we found that helpful. Actually, our association is meeting and learning about those columns, which is great. We had found that there is a means of a program for people under 65 that is, but we had questions about that and if the possible expansion of that program, because it does cover people 18 to 65, but from what we heard, gosh, I wish I could remember that young lady's name. I apologize. That nice young lady who was speaking with us after Dawn had to go, that program was, I believe, limited to like 100 people. It's the program for disabled. So when we got back together with the association and spoke about that, we wanted to explore the idea of expansion through possibly being able to utilize more of that program, if that's a possibility. And then also we had spoke with the program through DSS, Ms. Dorian's program, not the one that Ms. Dorian works with. And we had also found some additional information there about the approval process. That one actually is approved through the social worker and the member's physician. And we were able to find the information where the person's physician deems them appropriate for either home services or adult day services. So we just wanted to see if we could talk more about the expansion of either of those programs in an effort to increase enrollment or give us more avenues to enroll members to adult day centers.
What are the names of those programs?
One, I believe, was the program for disabled. Miss Jennifer or Dawn could probably tell us.
Well, the protective services for the elderly, that's what you're talking about.
The
social-
Swiss.
Oh,
It was
the-
Swiss one.
Yeah, there was.
And then the other one was disabled.
The Connecticut Home Care Program for the disabled.
That's
Mhm.
it. Sorry. I'm sorry. I didn't have the right term. Sorry about that.
That's okay. That's why we're all here.
I take notes. I promise I'm not sleeping. When I'm looking down, it's because I'm writing. But then I don't always have it together.
You do a very good job.
Thank you.
Anything else that we should have on our list? Okay, what do we want to know for the next meeting so that we can come out with the ideas that we want to pursue? And are all these ideas viable, even, something that we would even put forth, We don't want to beat our head against the wall on something that we know just isn't going to happen. And I'm sure some of you, like Dawn and Jen and Meg have, and Margaret, have seen this before, because I don't think it's new looking for support for these programs. Is there anything in these that we've just looked at that you think just we shouldn't even think about anymore? No?
Well, are some of the things, should we separate between things that need actual legislation and appropriation and those things that maybe we can engage in without legislation? For instance, the public relations concept we talked about, and, is it something that we work with the access agencies to talk about? Is there a different way to phrase it and make sure that people aren't referring to it as adult daycare?
And how do we reach out
Right.
to
So
the public?
that doesn't need to necessarily be legislated unless we want to. And I think if we come up with a different term or a better term, and if DSS has to change their coding, they can change that, right, without legislation. So I think maybe we take that and put in a different side, and so that we can put a priority maybe on, additional funding to separate transportation or to enhance transportation. We know that staffing is being taken care of or being pushed in the workforce. So maybe we could request that adult day be included in all of the efforts on the workforce piece. And it doesn't have to be a separate adult day staffing workforce piece, but we do something to encourage that. But of course you have to look at across the board, because we're all being paid different different rates, that obviously we need to look at the need to reimburse to pay the wages that people need and require, right? To recruit. And so
One's a question like, where's the 3.5 million? That's we don't need, you're right.
One other thing that we.
So I think, if we wanted to
just-
focus on that
oh.
other waiver program or
Sorry.
expanding to people under 65.
Yeah.
One of the other things we had been working on with Miss Jennifer and her team, we had mentioned it, but is actually completed now, is a training piece, presentation about adult day services, the benefits to the state, the benefits to the access agencies, and with Miss Jennifer and her team are going to be providing that to the access agencies as a training. So to create more awareness of our service for people that may not know the benefits of referring to an adult day service and things like that. So we'd be glad to, maybe we could share that with the group, and, it's a 10-minute presentation, but people could look at it on their own time and give any feedback. Maybe we could share that. That would be great too.
And just to see, the association did share it with DSS at our last meeting, and it's was really fantastically done. And I think nicely packaged, short 10 minutes, and I think really helps to explain the benefits, certainly to the member, the family, as well as, the cost savings in terms of, what they're provided, for the rate.
Can you share that with Cameron, Chrissy, so that he can send it out to all of us? I would love to see it.
Chrissy, is it a video or a presentation or a PowerPoint, and what format is it in?
It is I want to call it a movie, but I know it's not a movie. It's a PowerPoint made into a video with a professional voiceover that was
Really?
done for us. We actually have been working on it for several months. One of our providers from Elder House was able to get someone to donate time to do a professional voiceover. And it really came out. We're very proud of it. So we're not going to be entering in any festivals yet. But if you do see it in the future, you'll know that you got it first from us. We will be glad to share it with everybody. Thank you.
Okay, great.
Julia, did you have any other recommendations for our, report out on this group?
I'm sorry, and Representative Hughes, did you ask me? Is that what you?
Yeah, I
Oh.
thought I saw your hand raised as we were discussing report outs.
Yeah, no, my hand wasn't up. I was just the whole time thinking about the messaging and re-educating our staff. We have over 200 care managers who are helping develop care plans. And I was thinking the whole time, is there a way to re-educate them, to put it to the top of their list? And I know we've been in communication with Jen as well on some of the issues that we're experiencing with Adult Day and how we're messaging that. So the time is right to do that. And so it's wonderful that there's a video, and I'm hoping that it's kind of teed up for the audience of a care manager.
Yes, it definitely is, Julia. I think that your team will find it very helpful.
Great.
Okay. So is there anything else? No? Okay, well, Cameron will write up these notes. And we'll finish up on our last meeting. Looks now to be on November 10th. Okay, right, Cameron? Yeah. November 10th. And if there's anything in between, I may call a few of you to help me with a few of the points. I still want to know more about PACE.
Hey, November 10th, we have the full MAPOC Council, is that correct? At 9:30?
Yes.
That's going to overlap. I mean, I'll have to jump off onto that. It's weird because it's not usually on a Thursday, but yeah, that's.
Friday is a state holiday, so that's when they move.
Oh, okay, that makes a lot of sense. I mean, it's fine if we want to have it 9 to 9:30 or something. I just have to get onto that. And several of you probably do too.
We're open to another date. That's just the date that was chosen in our first meeting when we were doing dates.
Oh, okay.
That's all. We were going every other week.
I know we listed the 17th as a potential day because the 4th of the month would have been on Thanksgiving. Could the 17th work?
Fine for us, fine for me.
For me.
I think so.
Yes,
Yeah.
so we'll do it the 17th at 9 a.m.
Yep.
Okay. All right, well, thank you, everybody, for being here. Go out and enjoy this nice, beautiful, sunny day. If you can.
Thank you.
Take a
too.
walk.
Good work.
or
Good
something.
work.
Thank
I'm
you.
excited.
Thank you, everybody.
Proud of you.
So much.
Bye.